Good day, everyone. I am Dr. Shivani Katal, and my topic is What's Beyond Appendicitis? CT and ultrasound imaging in right lower quadrant abdominal pain. Introduction. Right lower quadrant abdominal pain is one of the most common cause of patients' visit to the emergency department. Although appendicitis is the most common cause of acute right lower quadrant pain, a broad spectrum of common and uncommon entities may mimic it both clinically and on diagnostic imaging. Various pathologies include inflammatory processes, infectious diseases, benign and malignant tumors, and miscellaneous conditions. CT and ultrasound are complementary imaging modalities. Ultrasound is done first, followed by CT for problem solving in inconclusive cases. The main aim of the study was to present ultrasound and CT findings in acute right lower quadrant abdominal pain with an attempt to correlate ultrasound and CT features with clinical presentation and operative findings wherever possible. This study consisted of 100 patients presenting with acute right lower quadrant pain referred to the Department of Radiodiagnosis for imaging, with exclusion of patients who refused to give consent, patients with contrast allergy, severe renal failure, multiple myeloma, and pregnant females. Ultrasound included radiate compression technique, and CT was done with IV contrast with images assessed in three orthogonal planes. Coming to the results and discussion, majority of the patients were in the age group of 21 to 30 years, followed by 31 to 40 years, with 54 males and 46 females. Clinical features in addition to pain were fever, vomiting, anorexia, weight loss, and diarrhea. Major diagnosis was acute appendicitis in 21 patients and its superadded complications in 16 patients, followed by ileocecal tuberculosis, ectopic pregnancy, ovarian dermoid, abscess, ureteric calculus, intussusception, colitis, hemorrhagic ovarian cyst, mesenteric lymphadenitis, endometriotic cyst, and ovarian torsion. In appendicitis, ultrasound findings included non-compressible blind-ending tubular structure more than 6 mm in 33 patients, and on CT, appendicolite was visualized in 21 patients with enlarged appendix mural enhancement, periappendiceal fat stranding. Appendicular complications included appendicular phlegmon, appendicular abscess, perforated appendix, which was seen in 5 cases. On these CT images, first image is showing inflammatory mass in RIF in coronal plane, and second image in axial plane, a collection is noted which is involving adjacent musculature. In tuberculosis, on ultrasound, ileocecal wall thickening was seen in 9 patients with enlarged mesenteric nodes in 14 patients and ascites in 15 patients. On CT imaging, thickened ileocecal wall was seen in 15 patients as shown in these images, with other features including surrounding fat stranding, necrotic lymph nodes, and ascites. Among females, ovarian dermoid was diagnosed in 7 patients, with all of them showing fat attenuation, calcification, and soft tissue component on CT, and complex cystic appearance, fat fluid level, and dermoid blood on ultrasound, as shown in these images. Ectopic gestation was found in 14 females on ultrasound. Among these, well-defined ectopic TSAF was observed in 12 patients with visualized fetal pole in 3 patients. Heterogeneous adnexal lesion with positive pregnancy test was seen in 12 patients. First image is showing free fluid and second image is showing ectopic TSAF. In one patient with ovarian torsion, enlarged edematous ovary with peripherally arranged follicles was seen. No flow on color Doppler was seen with deviation of uterus. In hemorrhagic cyst, on ultrasound, septated cystic lesion was seen in all 3 patients with retracted clot in 2 patients, as shown in this ultrasound image. On CT, hyperdense cyst was observed. In endometriosis, cystic lesion with homogeneous ground glass contents was seen in all 3 patients, as shown in this image. Right ureterolithiasis was found in 7 patients. On ultrasound, hyperechoic calculus was seen, showing posterior acoustic shadowing with proximal SDUN. On CT, hyperdense calculus was seen, as shown in provided images. Intussusception was found in 3 patients. On ultrasound, target sign was seen, as shown in the image. Prolapsing part of the bowel is intussusceptum, and the outer part is intussuscipium. On CT, sausage-shaped mass was seen with mesenteric fat and vessels dragged inside, as shown in the image. Mesenteric lymphadenitis with enlarged nodes was found in 3 cases. In 3 patients with syphilitis, Thickened cecum and ascending colon with surrounding fat stranding was seen, as shown in the image. Abscess formation was found in 5 patients, showing peripherally enhancing collection. In first ultrasound image, anterior abdominal wall abscess is seen, showing bright echogenic air foci within. Second image of axial CT is showing abdominal wall collection extending into the peritoneal cavity. Acute RAF pain is a common chief complaint in clinical practice, and the differentials include a broad spectrum of clinical entities ranging from benign self-limiting disorders to illnesses associated with high morbidity, requiring the clinician to make an urgent therapeutic decision. Prompt diagnosis is essential to minimize morbidity, which remains substantial if a complication occurs. Ultrasound is the first-line imaging, especially in children and young females. CT imaging is excellent for equivocal cases and complications. Recognizing mimics avoid misdiagnosis. Multimodality approach improves diagnostic accuracy. Coming to the conclusion, ultrasound in CT is an effective imaging modality with results that have a positive effect on the management of many patients with acute right lower quadrant abdominal pain. Familiarity with imaging spectrum aids timely and accurate diagnosis. Radiation exposure is a drawback of CT, but ultrasound may serve as an initial diagnostic test, followed by CT reserved for patients with non-diagnostic ultrasound results. These are my references. Thank you.